So hi everyone, I'm Dr. Arij Alkayyali. I would like to welcome you all and thank you for joining us today. First of all, I would like to introduce our office. Our office is Alliance Dental Specialist. It's located in Oakville, Ontario. And I would like to introduce as well our team that include the two endodontists, me, and we have as well Dr. Yusi Namayas with us today.
Hello, hello.
Okay, so we have as well our supporting team. I'm going to start from left to right. We have our manager, Arij, our receptionist, Shailene, and our great supportive assistant, Susan, Barbara, Tony, and Viviana.
Well, I just want to say a few words. I'd like to welcome everybody to this meeting. I think it's going to be a phenomenal lecture.
Endodontic diagnosis. Today's lecture, it will be about diagnosis. Our learning objective is to include understanding the steps that lead to diagnosis and to learn the diagnosis terminology. I will share with you clinical tips for the challenging cases that will help you to look at the cases from different perspectives. Correct diagnosis is a 3/4 the remedy. That's a saying by Gandhi, and I strongly believe in this saying because as simple as it is, if you misdiagnose, you're going to mistreat. The diagnostic objectives, majorly it's to reduce the chief complaint, to determine the cause of the chief complaint and to eliminate the cause of the chief complaint. We need to be careful that we shouldn't start the treatment based on an assumption, simply because you will mistreat the case. And we all need to keep in our minds the oath that we have, Hippocrates oath, do no harm. It's very important segment, just not to harm the patient. It's acceptable and even ethically required that not to guess the diagnosis or the treatment. And try your best through the testing to find what's the problem. If you couldn't, there are solutions for that, and there are ways that can help you, and I hope you will learn it today with me, that strategies that can help you to find the diagnosis, even in later sessions, if not in the first consult visit. First of all, we start usually in the consult appointment. I have simple question. What's the first question you should ask your patient? I hope you don't jump into the chief complaint. First of all, you need to know your patient. You need to know the medical history of the patient, how that is relative or important to you. Can I treat the patient safely? Sometimes the patient might have seizure history, which is active. This, you cannot do root canal treatment for them unless you do a GA. Sometimes the patient has a heart attack last month. You shouldn't initiate any treatment on them right away until they are controlled. Does the need pre-medications for joint replacement or a heart defect? Does the patient has allergy to the local anesthesia? Last week, I had a patient who has allergy to local anesthesia, and he's not even aware what kind of anesthesia that caused him the allergy. He just was hospitalized after he was given the local anesthesia. Is he allergic to antibiotics? Is the patient hypertensive? How much epinephrine you should give the patient for hypertension? All these questions you should be prepared for. Does the patient need sedation? And what are the contraindications for sedations? What is the patient's blood pressure? Do you take blood pressure for each patient? Me personally, I do that for consult and the treatment. Why? Because I want to prepare my treatment based on the patient's situation. Sometimes I have patients' blood pressure was 200/116. I had to call the paramedics immediately for this patient because I repeated taking the blood pressure and keep going up and up. So this patient is about to have a heart attack in my chair, and I was about to start a root canal treatment because it was a consultant treatment. So it's your responsibility to make sure that the patient will be safely treated under your supervision, and you need to be prepared to know your patient more before you start doing the consult and figure out what's the problem with the tooth. We don't treat teeth, we treat patients. So now the very structural part about the diagnosis that we start after we pass with the medical review. What's going on with the patient? So the standard diagnosis framework that we are using, it's called SOAP framework. It consists of, it's like a puzzle. It consists mainly of subjective information, objective findings, the assessment, which is the diagnosis that you're going to reach, and the plan of a treatment, which is the treatment option you're going to recommend, and the treatment the patient will approve as well. Subjective information. This information we get from the patient, and it's guided by your relevant questions and careful listening to the patient. You shouldn't rush this part of the questioning of the patient, because that will guide you through the process of testing to replicate the symptoms the patient have. The history of pain, for instance. To begin with, when did it start? If it start, let's say, 1 year ago, then it's not an acute situation. It could be chronic apical abscess, it could be a chronic infection, it could be a cracked tooth, it could be non-odontogenic. Something happened more recently. I didn't wake the patient up, let's say, last week. If that something happened, then we expected either irreversible pulpitis or even maybe necrotic tooth. The stimulus of the pain. So what can cause the pain? Would it be cold? How long does it last? Is it heat? Sometimes with the cold, it can create a relief for the patient, and that usually happens in the latest stage of irreversible pulpitis, where the heat start bothering the patient and the cold create a relief because of the micro abscess that is created inside the tooth expanded with heat. Would the biting be a problem? You might think that there might be infection under the tooth, or maybe there is a crack in the tooth. Can the chewing be a problem? Is it touching just the tooth, which might indicate a more acute situation happening there? Is it the pressure? What about pushing the gum? When you push on the gum as well, that might indicate that there is an infection going on or inflammation under the tooth, or maybe periodontal. Or if there is no stimulus at all. Now about the severity of the pain. How severe it is from a scale to 1 to 10. We need to keep in mind that the patient, sometimes the pain threshold might vary. People might have a very low threshold and they indicate it's 9 or 10, but it's not that bad. It could be a chronic thing. So you need to keep that in mind. So they might exaggerate. The frequency of pain, how often the pain happens. Does it happen more constantly, or it happened once or twice a month for the last year, which might indicate more a chronic situation like a crack or a chronic infection. The duration of pain, how long does the pain last? Does it last less than 30 seconds, especially on cold stimulation, which indicate reversible pulpitis, or more than 30 seconds, which indicate irreversible pulpitis? The location of the pain. So if the pain is localized, which indicate more of the periapical problem, that's more localized like apical periodontitis, or more sporadic, like it's not in a certain arch, it's in the right and the left side. So if it's not localized, like it's in both sides, it's more indicative of non-odontogenic. If it's localized to an area, but the patient cannot locate which tooth is related to the pain, it could be irreversible pulpitis or non-odontogenic. The spontaneity of pain, how spontaneous is the pain? And that's usually indicative of irreversible pulpitis. Now, for the objective findings, the clinical exam, radiographic assessment, and comparative testing. Those are the 3 parts that can help us as well to do our objective exam. We're gonna go through them in detail. Clinical examination, which has 2 parts, extraoral exam, that include the submandibular lymph node testing to check if there is an infection spreading there. And keep in mind, when they are palpable and tender, it might be the sinuses as well, not only the teeth. The TMJ as well as extraoral exam that indicate if there is a TMJ problem or myofascial pain when you test as well the muscle, because sometimes that can mimic the endodontic pain. Intraoral exam. So you need to, first of all, to have a visual exam of the area. I cannot emphasize enough on documenting everything that you see, even if it's not relevant, because as we know that it might be relevant later in later stages. So we're going to start first with palpation. When you do the palpation, you're going to check if it's tender or not, and that indicate an inflammation happening inside the jaw, and that's related to infection under the tooth. Percussion, when it's percussion sensitive, it might be endodontic or periodontal, but you need to make sure that you do it in a vertical axis, and you need to make sure that you start with the teeth that not suspected to have the problem, because you need to make sure that the patient feel what's the normal. Sometimes you have to use the other arch or the opposing, the other side of the jaw to test the teeth that mostly virgin teeth. You need to watch as well for swelling. The presence of a sinus tract is important to assess as well. And we're going to talk as well more in detail about sinus tract tracking and the sinograms. You need to detect the cavities, if there are cavities, as a possible cause of endodontic infections. And if there are fractures in the teeth or the cracks as a possible cause of endodontic pain. You need as well to check if there are fracture or extensive restoration, like deep restoration, or because that could be a possible cause of endodontic infections as well, and pulpitis. Periodontal disease, we need as well to make sure that not only to assess for endo as well for perio, because periodontal health of the tooth will affect the prognosis overall after, especially when the patient has a mobility grade 3. This means that the tooth is hopeless and there's no point to keeping the tooth, even if the nerve was in a good condition. Exposed dentine, which could be related to sensitivity that's not lingering. Wear of facets. The wear of faces that might indicate the patient is a grinder, and that increases the suspicion that he might have a crack somewhere. Now, for the periodontal probing, I'm not sure how all of you, which kind of a prop you are using. So I know that the standard is to use the metal one, but me personally, I prefer to use the plastic ones because it's more flexible. It can detect a deeper pockets. I prefer the yellow ones that has serration on it by millimeter than the white one, which I feel it's a little bit wider. And this is my favorite, actually, the yellow one, to use it in every patient. You need to, when you do the periodontal probing, to check the adjacent teeth as well, to make sure that the patient may have another periodontal condition that needs to be periodontally assessed by the periodontist. Now, for the objective findings and the radiographic assessment. So this case on the left, it shows an X-ray taken in a bisecting angle. And it was taken by a general dentist who referred the patient for tooth number 16. He suspected that there is an infection under that tooth and he need an endodontic assessment by the endodontist. However, the X-ray on the right side, it shows a periapical X-ray that's taken by the endodontist with parallel technique. You can see the difference by the angulation, that we can detect now a deep cavity under the restoration in the distal aspect that approaching the forcation area. He has a deep pocket in the distal side that a lot of bone loss can show there, that a periodontal involvement effect. You can see the curvatures of the root as well, which make the case a little bit difficult to treat and maybe difficult to retain as well. All these things were missed in the first radiograph. So angulation here is important, and the technique that we're supposed to use is the parallel technique to begin with. Now, for the sinogram, whenever you see a sinus tract, try to trace it. Why? Because this will be a confirmation for your testing that this is the tooth that you should treat. Now, your X-ray is supposed to be complete. And whenever you have that you need to check, you need to make sure that the tooth the tooth that you want to assess, it has to be in the middle of the X-ray. This case came to our office, and we detected the tooth number 34, sorry, has a periapical infection, and the 37, it was fine, although it has an open margin on the mesial aspect, and that could be a leakage and maybe a possible decay under there. However, the patients only wanted to treat the tooth that has a problem. The 37 was vital, the 35 was necrotic. So root canal treatment was done. And when we took the final X-ray, we detected that there is something happening with the teeth. Another X-ray taken, and we noticed the problem spreading more anterior, and more testing need to be done. This case as well would indicate that you should test all the teeth, like the teeth beside the tooth that you are suspecting has a problem. Sometimes you might get a negative result and you think it's just because it's calcified, because you got a negative results on the other teeth. So you need to use a different testing, like electric pulse testing. Now, radiographic assessment. The buccal object rule, we all know the same lingual opposite buccal. So on the left side, you see an X-ray taken from the buccal straight view. This tooth was root canal treated 4 years ago. The patient came back for periapical complaining of symptoms on the 4/6, and we can see the periapical infection on the X-ray. It shows that the root canal was filled all the way till the end. However, when a distal view was taken for the same tooth, you can see that the root canal is off-center, and seems there is a missed canal that causing the infection in this area. And per the buccal rule, that same lingual, the root canal filling there, it indicates that the filling was in the mesiolingual canal, and the mesiobuccal canal is the one that was missed. Now, this case I treated last year, and the patient came complaining of tenderness, very mild, but the dentist noticed a periapical lesion on the 1/6. Wasn't sure if it's 1/6 or 1/7 because the 1/7 testing on cold was not conclusive. We did the sinogram, and we noticed that it's more confusing now because it's coming on the distal root of the 6 and the mesial root of the 7. However, when the X-ray was taken, I noticed that it wasn't taken in the right angle. It wasn't taken in a straight angle. It was taken more in a mesial direction, which pushed, showed that it going more towards the mesial. Now we took it in a straight one, and it's more indicating of the 1/6. Upon opening the tooth, we found it necrotic and infected, and the root canal was accomplished for the patient. However, the 1/7 on the treatment session, when they brought back the patient, we tested it, and it showed more responsive. At that day, the patient took painkillers, and I guess that affected the reading as well. Now, CT scan, well, I cannot emphasize enough about the CT scan. I love those CT scan because it can show more than what we see in the 2-dimensional X-ray. This is one of the cases that when you, on the first look, you would suspect that the tooth might be infected. However, of course, on the cold and electric pulse testing, it should indicate if it's vital or not. Sometimes it might not be conclusive, though. I guess in that case, it wasn't conclusive, and the patient was sent for a CPCT. And it clearly shows that there is a simple cyst happening there, and that needed monitoring. Now, this is as well one of the cases that makes you think what's going on, that both teeth tested vital. Sinogram was done because there was a sinus tract, and there is something going on in between the two teeth. So a CPCT was taken to figure out what's going on because we felt it might be non-odontogenic, something related, or it could be periodontal. And it came with confirmation with aggressive localized periodontitis. Now, there is another technology. I don't think it's applied, but it was interesting to me. So I just wanted to share it with you for knowledge. Sometimes they do ultrasound examination to visualize and trace the sinus tract to know which tooth is related to it. It's just something interesting. Maybe in the future it would be accessible for us. So for this part of the lecture, I would like to share the clinical tips. So for imaging, it must be current. Current for me, it means three months, because in 6 months, things might change. Usually when we have any case referred to us, we take a periapical X-ray regardless when it was taken, to be honest, just because we want to make sure we get the right angle and we have it complete. So when you complete, meaning that the tooth has to be in the center of your X-ray to show the adjacent teeth as well, because that's where your comparative testing will take place. Palpation, get the patient accustomed to normal. So you need to make sure that when you test the teeth, you don't go right away to the tooth that bothers the patient. You step up at least one tooth beside it, or even two teeth, depends on the situation. If you have infection under the teeth adjacent, you want to find something more normal so the patients will understand what's the normal for them. Start with uninvolved teeth and the percussion. Usually when I do my testing, I start with palpation, percussion, bite test with the tooth sleuth, and then I will do the cold testing. And the last thing I will do is the perioprobing, because it's tender and it makes the patient sometimes ache. So I don't want to confuse that with my cold testing. And if the patient has high, like complaint of pain, severe pain on biting, you need to be gentle when you do the percussion on the tooth, maybe gentle tapping in the beginning. If he doesn't feel, then you might consider increase the tapping a little bit more. Mobility, we all know the grades of mobility, 1, 2, and 3 with vertical movement. So level 3 is important for us to know, because this means that we need to extract the tooth because it has hopeless prognosis. Now, for comparative testing, the thermal test is supposed to be cold, and we need, as we said before, it needs to reproduce the patient's chief complaint. My favorite method is to do the endo ice. Some people might like to use freezed water, like they put it in the needle caps. Some people might use the CO2. I like the endo ice because it doesn't drip on the gum. If you're gonna try to use the heat, make sure you use the petroleum jelly on the tooth, so the gutta-perca will not be stuck on the tooth for a long time because it's hot, and it will create more irritation for the patient. Now, for the cold testing, you want to inform the patient, because sometimes the patient will misunderstood what you want to do. You want to explain before you start the procedure that you're going to apply cold. You want to know when it starts and when it stops, and you start counting in between. If it's more than 30 seconds, this is more indicative that it's a reversible pulpitis. If it's less than 30 seconds, then that's more indicative of reversible pulpitis. Keep in mind that in the latest stage of irreversible pulpitis, the heat is what causing the problem, and the cold create a relief. So that might vary with your results as well. Bite testing. So we ask the patient to bite on the tooth slope, bite hard and open quickly, because most of the pain that we are looking for is upon the release, and that's mostly indicate either infection under the tooth or there is a crack on the tooth somewhere, and you need to test all the cusps. Always start with the adjacent teeth that you don't suspect, and after that you start with the tooth that you're suspecting. Electric pulp testing, keep in mind that electric pulp testing is very helpful, especially when you have a negative reading on cold, but it doesn't make sense to you because you expected that this tooth is vital, or you want to confirm that the tooth is necrotic, then you're going to do the electric pulp testing. Some cases, it might give you a false negative. Some cases it won't work, especially if you have a crowns. So when the patient has a crown, I found the best way to test it is by cold and endo ice. Apply the cotton on the top of the tooth or from the buccal side and leave it till you stop feeling the freeze on the tweezer. So keep it at least for maybe 15 seconds or 10 seconds. So you need to wait. And always when you do the cold or the heat testing, you need to give time for the tooth because sometimes you might have a delay. Happening, which might interrupt the testing of the other tooth. Now for transillumination, it's very important if you suspect a crack. Ideally with a crack, it's the best to check it with a microscope, but I know that some of the dentists, they don't have microscope, or most of them, they don't have microscope in their offices, so at least you can use the transillumination light to check if you have a crack, especially if you have a big amalgam fillings. Now, if you detect the crack location, I would suggest that you try to repeat the pocket measurements again and try to target the area where the crack is from the buccal and the lingual aspects. Selective anesthesia, it's most helpful in the cases where the patient believes that the problem is in the lower jaw, let's say, or the upper jaw, and you know that the problem is the opposite side. Or you notice that the patient start having the aching or the pain, and you don't know if it's in the upper or the lower. At least you would localize it to one arch, and you can bring the patient again for repeat the testing after a couple of weeks, or you can investigate further. Now, if you do the selective anesthesia and you are suspecting two teeth in the same quad, it won't be helpful for you because selective anesthesia will spread and cover the teeth in that quad. Cavity testing, I wouldn't do it. I hope nobody is desperate enough to do it because the patient will not like it. They will be reluctant to do it. That's when you suspect that the tooth is vital, but it's keep giving you a negative testing. So you drill the tooth without freezing and wait till you get a response, or I guess till you reach the pulp, but I wouldn't do that. But sometimes there are desperate measures. Now the clinical tips for this part is for cold, air water syringe is inaccurate. So when they say I want, it's bothering me when I drink cold water and you cannot produce it, I would suggest that you use a rubber dam and you get a syringe with cold water and try to irrigate on the tooth and keep moving the rubber dam on the teeth that you suspect that has the problem. If you spray the air, it goes everywhere, it won't be conclusive. Same thing for me is the ice stick. I know my colleague, he likes the ice sticks more. I like the endo ice more. So it's up to your preference how you handle things, but it has to be reproducible for you. For the heat, as I said, don't forget the petroleum jelly. You don't want the gutta perca to be stuck on the tooth and it will be hurting him for a long time. Usually what we use is we have the calamus or the obtura that you heat the gutta perca and you apply it on the tooth. Selective anesthesia, as we said, may anesthetize the adjacent teeth, so it won't helpful in the same quad. It will help you if you are suspecting between two arch, or even to confirm for the patient which quad is causing the problem. So I had a patient a couple of weeks. She believes that the problem coming from the lower arch. When I tested her, I started with the lower arch because I know it won't cause any pain. Then I went to the upper arch and then she said, oh, I feel it, it's in the lower now. So I started freezing the top and the pain disappeared. So then she was convinced that the problem is in the top and in the bottom. So I always aim to freeze the area that I suspect it causing, that I know it causing the problem, and start with the area that I suspect it's not a problem. Cavity testing, as we said, the patient will be reluctant to do it. Still, you need to explain it to them before you start with it and get their approval, of course. Now, after all that testing that you've done, I hope we can reach to diagnosis. Diagnosis should indicate the pulpal and the periradicular status and the kind of treatment that needed to rectify the problem. So when you read your diagnosis, it's not supposed to be, say, pulpitis or abscess. You need to combine them both because that will indicate what kind of a treatment. And don't forget as well the periodontal to be included. So today we're going to talk about the diagnosis, pulpal diagnosis, apical diagnosis, and briefly about the non-endodontic pathologies. For pulpal diagnosis, first of all, normal pulp. The patient have no symptoms. When you test the tooth, it tested vital, responsive on the cold testing for a few seconds, less than 30 seconds. And that doesn't require any treatment. Reversible pulpitis is the patient may complain that they have sensitivity on cold that lasts a few seconds. And when we tested, it might be sharp response to the cold, but it lasts less than 30 seconds. Irreversible pulpitis, could be symptomatic or asymptomatic. Symptomatic, that when the patient complains that I have pain that lingers, pain wakes me up at night, pain starts by itself. Any of those indicative that there is irreversible pulpitis. When you test it, the cold sensitivity lasts more than 30 seconds. However, in asymptomatic, the cold testing might be getting back with a normal, like less than 30 seconds. So, but the only indicative that the patient has a big cavity that including the pulpal chamber. So that indicative that the nerve is inflamed because you are sure once you clean that cavity, you will end up in the pulp chamber completely, not just exposure. Pulp necrosis, the patient doesn't complain about cold sensitivity, maybe biting because the infection starts spreading under the tooth. And when we tested, there is no response to cold testing, maybe to hot testing. Keep in mind with irreversible pulpitis, the patients may come with different scenarios that it might be sensitive on cold that lasts more than 30 seconds, or the pain starts by itself, wake me up at night, or when I apply cold on it, I have a relief. And that's when the patient is heading toward the latest stage of irreversible pulpitis. And the hot is what causing the problem. It's creating or stimulating the pain. Previously initiated therapy is when the root canal is started with pulpotomy or pulpectomy, but it wasn't obturated. Previous root canal therapy is when the root canal was obturated either surgically or non-surgically as well. That the root canal obturated and they did it with or without surgery. Now, apical diagnosis, normal apical tissues that on the X-ray it doesn't show any radiolucency, and when you test it on biting and tapping, it tested normal, no tenderness. Symptomatic apical periodontitis, when you have a periapical lesion and when you test the tooth, it's tender. So on biting or on tapping. Asymptomatic apical periodontitis, that's when you have a periapical lesion obvious, but the patient has no symptoms, and when you tap on it, there are no symptoms. Chronic apical abscess is when you have a sinus tract, a draining abscess on the tooth. Acute apical abscess, that's when you have a swelling. Condensing osteitis is a condition that can go with any of the above cases. That's low-grade inflammation happening under the tooth that makes the bone to be condensed. It depends on the situation of the tooth. If it's necrotic, you need to do root canal treatment. If it's just a filling, maybe you want to consider replacing that filling if the tooth is vital. So that's come with any of the above. Okay, now for non-endodontic pathology. Non-endodontic pathology, it's when the condition not related to the endodontic infections, acute periodontal abscess, which might mimic the endo, but the difference is that with acute periodontal abscess, the tooth is vital. Most of the time, the patient will come with a swelling, even it might be spreading to the submandibular lymph nodes. And usually this happened after the cleaning if the patient had deep pocket or if they had something that slipped inside the deep pockets like a popcorn most of the times or like sesame seeds. It might make that. So it will be helpful if you ask the patient with such a situation if they have a recent cleaning, and this might help you as well with testing the tooth to make sure that it's vital. So this make usually that's the scenario that I'm facing in those situations. Vertical root fracture, which might mimic an endodontic pathology as well. That's usually happening in the buccolingual direction. Acute, and it's, of course, it's a hopeless. So the option, if it's single rooted, would be extraction. If it's multi-rooted, it would be maybe root amputation or extraction. Depends on which root. Acute chronic sinusitis, which might mimic teeth, an endodontic pain. Usually all the teeth in the area are tender. Most of the teeth would be vital, but the patient complain about it. So one of the things that you might find it strange, but I find it working. Sometimes you ask the patient if they have sinus issue, they might say no. So what I ask them just to stand up and bend over. And if they feel pressure on that side of the face building up, and that's usually the fluids in the area. Keep in mind that sinusitis, like 60% of them could be related to dental infection. So if you get a negative results when you do cold testing or electric pulp testing on the area, it might be a combined sinusitis in that side, it's caused by the endo, or it could be a primary sinusitis. So if you do the root canal treatment and the sinusitis heal, it's related to the endodontic problem, to the teeth infection. If it's not, so it could be separate thing. Now, myofascial pain disorder, as well, it might mimic teeth pain, but you need to palpate the muscles from the extraoral and from the intraoral, the masseter and the pterygoid muscles. And you need to check if there's as well occlusal trauma. So if there were restoration done recently and it was high, so the patient as well might feel tenderness on the tooth, but it doesn't need root canal treatment. It needs as simple as just occlusal adjustment. I remember vividly one of my cases, it was referred to me to do retreatment for the tooth. The dentist, he just did a recent filling. He changed the filling on the tooth, and after he changed it, the tooth started to be symptomatic. So as simple as just checking the bite and adjusting the bite in that appointment, the patient felt better. Because the root canal seems fine, there was no infection under it. It doesn't seem like there is a problem. Of course, we need still to check with the CPCT to make sure that there's no hidden infection, but in that case, it was very obvious it's the occlusion problem. The neuropathic nerve pain, like trigeminal neuralgia, it might mimic as well the endodontic pain. However, you need to find the trigger point. You need to ask the right questions. If the patient having the pain, let's say after shaving or the shower, how is it chronic? Like if they say, especially it's been 4 months, it comes and goes every like 6 or 8 weeks. Every 3-4 months, I start feeling that episode of pain, which is a sharp, severe pain that wouldn't be an endodontic in nature. Vascular pain as well. And atypical facial pain. I remember 20 years ago, I had one case of atypical facial pain. The patient came to me asking for root canal treatment. He already did a root canal treatment for upper molar and did a retreatment for that tooth and ended up extracting it and thinking that the tooth beside it is the problem. So after testing, everything was normal. It was very obvious that it's atypical facial pain. So in that case, you should educate your patient that it's not the teeth. If I'm going to do root canal for all his teeth, he will still feel that pain. And those patients need to be referred to neurologist to help them with medications. Now, planning for the treatment. So as long as you understood and you have the situation and you manage to reach a conclusive diagnosis, you're going to start planning for the treatment. As a general dentist, you have 4 options. Endodontic therapy that you started as an emergency treatment or elective treatment, especially if the tooth is broken and you need to have a post inside the tooth to support the restoration. You want to do it electively. Or if the tooth is cracked, has reversible pulpitis, and you want to apply a crown, you can do it electively as well. Or extraction, if the tooth is not restorable. No treatment is always an option. By law, you need to give it to them so the patient, they don't feel they only have one option to deal with. However, when the patient has symptoms, you want to indicate that it doesn't make sense, but still you have to give it to them. When the patient is asymptomatic, it might be an option, especially if they don't have enough financials to cover the treatment plan that you created for them. Referral to the endodontist. Keep in mind that when you refer to the specialist, you open more treatment options to your patients if you are not offering those within your practice, like apical surgery, vital pulp therapy, revascularization and apexogenesis, and of course the trauma cases. Consult form. This form, I used to use it for a long time. Now I do it mentally. So you can have your own form. I know different software have different things, but that includes everything from the medical history, tooth number, chief complaint history, the exam, restoration, what kind of restoration on the tooth, palpation, percussion, probing, cold testing, APT, mobility, swelling, tooth sleuth. So that will help you and guide you. And keep in mind that we check as well occlusion, radiographic assessments, so you can easily reach to the diagnosis based on these tests that you go through one by one. So technically what we are doing as a specialist is not magic. We strictly follow those steps. And you can do the same like us. You can reach the diagnosis if you strictly follow the steps. And of course, offering the treatment options. Now I'm briefly going to talk about cracked teeth. I had a lecture before, it was extensive, but I felt like it's important part, and always it's a challenge for the dentist to diagnose cracked teeth. I understand why they don't have a microscope, but if you suspect it, you can always refer it. And maybe the scenario would help you to get the pieces together of the puzzle to be more conclusive of a crack. So we're going to talk about definition, types, and diagnosis. So it will be brief about this part. So in definition, it's a thin surface disruption of enamel and dentine and possibly cementum of unknown depth of extension. So should we say cracked tooth syndrome, the endless argument, longitudinal tooth fracture? It's not syndrome, because syndrome, it's like symptoms together, a group of symptoms that come together with a cracked teeth or longitudinal tooth fracture. It's not just symptoms that come together, it's very. So for the longitudinal tooth fracture, we have a crazed line, which and the transformation, the light goes through, so there's no actual crack. And it's commonly found in adult teeth and only involved in the enamel, often in unrestored teeth. And it's not easy to determine the extent and the depth of the crazed line, so you need to warn your patient. It could be a sign that the patient is a clincher, mostly. Fractured cusp, it could be complete or incomplete crack that extend on the mesial and the palatal side or the lingual side around that cusp specifically. So the cusp could be separated completely or just hold to the tooth by the filling. Usually when you remove the filling, the cusp fall down because it's complete. Cracked tooth, it usually incomplete fracture that usually extend on the mesial and the distal aspect, sometimes on the buccal or the lingual. Split tooth, it's a complete separation, complete fracture, usually in the mesial and the distal, and it extends subgingivally. With a split tooth, usually you need to remove the it's extraction case if it's extended deep. If it's a fractured cusp, you remove the cusp and see how deep it extends to involve the pulp. If it involves a knot, then you need to do root canal treatment and restoration with a crown. For the cracked tooth, the treatment varies. So if the tooth is completely asymptomatic, tested normal, I would recommend getting a crown to be a proactive. Keep in mind 30% chances might have nerve damage down the road. So either you do elective root canal before or just get a crown. I would recommend to keep the crown. If anything down the road, we can do root canal. If the patient has symptoms like reversible pulpitis, I would still recommend getting a crown. Still, I would explain for my patient the risk, and I will go moving forward to show you some evidence to support just to offer a crown for the reversible pulpitis. If it's irreversible, of course, we need to do either root canal or extraction, depends on the extent of the crack. And if it's necrotic, of course, it's root canal or extraction. For the split tooth, mostly extraction. And for vertical root fracture, if it's, as we said, if it's single rooted, it's extraction. If it's multi-rooted, it will be amputation or extraction. So the classical signs and symptoms: pain on mastication, cold, hot sensitivity sometimes, isolated deep pocket sometimes. So most of the cases that might be a puzzle for you, that you have a shallow restoration or no restoration at all. The patient has pain when he bites on the tooth, maybe yes or no with cold sensitivity, and you don't know what's going on. You suspect that maybe recession, maybe just intense sensitivity. So in those cases, ideally, we suspect that it's a crack. So there is a crack somewhere, and we need to look for that crack. So how we find it? With a microscope. 13 times is the minimum needed in order to see the crack or a fracture visually. You won't be able to see it in the loops, and that's based on that article in 2003 by Dr. Clark. So the steps for the crack, it's a long process because we have more specialized testing for the cracks. So starting with the dental history, I had a pain over a year, pain mainly, or maybe shorter. It could be on mastication mainly, it comes and goes. Or if it's become more towards reversible pulpitis or necrosis, become more localized and more tense, like last week it wake me up at night, or I have an abscess under the tooth. Subjective exam, you need to look at the area to check if there is a deep filling, especially amalgam restoration mostly have cracks under them. You need to keep in mind because 40% of the crack are missed under restoration. So when there is a restoration and you suspect that there is something going on there, you need to warn the patient that there might be a crack under the tooth, under the filling. Objective visual exam, that as we talked about it before in details, tactile examination, preapical testing, which is that include percussion, bite test, which is the most relative to cracks, vitality testing. We said it could be ranging from normal to necrotic. Periodontal probing, use the plastic probe that will help the most to detect deeper pockets. Radiographic examination, you won't be able to see much unless there's a complete separation, like in the vertical root fracture. Restoration removal, as I said, 40% of the restoration, if it wasn't removed, there was a missed crack under them, especially the amalgam restoration, because they expand with time and that create tension on the filling, or if you have an MOD composite restoration as well. Staining of the teeth, that can be helpful to detect cracks as well. So we use the green stain on the tooth, and sometimes you can detect it. Transillumination, we all know how that works as well. Wedging forces that you apply the pulp in between to create a wedging effect. It will be a little bit painful for the patient. I wouldn't suggest to do that often, because you might end up splitting the tooth as well, or breaking the cusp that you suspect it might be fractured as well. Surgical assessment, that's mostly for vertical root fracture. That's the only way that we can be conclusive, because sometimes on the CPCT, when it says that there's a vertical root fracture, confirm it because there's separation and the X-ray goes through the fracture line. That's a positive sign, that's enough evidence, but sometimes they may suspect a fracture. So when they say no, there might be a fracture and it might be missed because of the sensitivity of the CPCT is not 100%. Dental optic coherence tomography, that's a very nice technology that can show more than anything else. More cracks can be detected with that technology. I'm going to share it with you later. This is the transillumination. So you put it on one side, you try always from the buccal and the lingual from both sides. I usually, when I see a crack, I don't just detect one tooth. So I try to check as well the whole quad. Sometimes we detect multiple cracks and we catch them, especially if the patient comes with irreversible pulpitis on one tooth. I want to catch those cracks before it starts bothering the patient and extending even more. And we would suggest going back to the dentist to have a crown done. This is the dental optical coherence tomography. There was an article about it in 2015 by Sang-Hee Lee. It's very interesting. On the top left side, you can see the tooth by visual exam that can show only one crack. With the transillumination, it shows two cracks. With optical coherence, you can see three of them. With the CT scan, you can only see two, which is a micro CT. So it's very interesting technology. It seems sophisticated. I don't think it will be on the market because of the size. Maybe if they make it smaller. So maybe this is something for the future. Should I do root canal treatment for all cracked teeth? That's an interesting question. Let's share the evidence with it. So there was an article by Krell and Rivera in 2007. It shows that 20% of reversible pulpitis cracked teeth converted into irreversible pulpitis or necrosis within 6 months and require root canal treatment, with none of the other teeth requiring root canal treatment over a 6 years evaluation period. So 80% of the teeth that chose reversible pulpitis were asymptomatic and they survived up to 6 years. Does that worth sharing with your patient in decision making? It's up to you. Another evidence, when a properly managed cracked teeth with reversible pulpitis could remain healthy for 3 years or more. Another evidence, this about teeth that has cracks already that extend to the orifice up to 5 millimeter beyond, were included in the cohort study that they did. They did the study up to 4 years and they found this is 100% survival in the first 2 years, 96.6 up to 4 years. Overall, 90% success between 2 to 4 years if you have a crack that extend up to the orifice level. So it extends deep inside the crown, but it stops at the orifice. when should I make a crown for a root canal treated tooth? So that's the ongoing argument between the endodontist and the dentist. The endodontist wants the crown to be done as soon as possible. The dentist wants to see a sign of healing. So I'm not sure what do you think, but this is what the evidence show. It's exact fact in 2016, teeth that received a crown 4 months after root canal treatment were almost 3 times more likely to get extracted compared to the teeth received a crown within 4 months on root canal treatment. So if you do the crown within 4 months, you have a good chance or 3 times less susceptibility to fracture than more than 4 months. So that's why we recommend to do it as soon as possible. But the question is, what if it's cracked? So you need to get it as soon as possible. So when I have a cracked tooth, I wouldn't wait 4 months for it. I'll just say, if you want to save it, this is your chance. You want to get it restored, have a permanent filling done within 10 days, maximum within 2 weeks, because any restoration that we do it as a temporary will leaks, and that's define the purpose of doing the root canal, which is disinfecting the tooth. So we start having leakage on a 2 weeks mark. So, and it's sad when the patient come back after a month or 2 and they still have a temporary filling, and we notice that there's a big leakage, and we have even to redo the root canal treatment for them. And for the crown, of course, for the cracked teeth, it has to be done, I believe, immediately, as soon as possible. Endoperioral lesion. This is a very extensive topic. I'll make it simple. First, we have primary endodontic lesion. Primary endodontic lesion, it might have deep pockets, like draining beside the tooth or draining from the side, but the gum is not involved. Now, endoperio, it could be primary endo, secondary perio. In this case, it's primary endo that the tooth is necrotic, and we have a blowout radiolucency around it. Once we do the root canal, everything will heal. Primary perio, secondary endo. In this case, you can see that there is a bone loss up to the mid root, and there is a periapical lesion on that 2-5. Let's go back. So after it was root canal treated, you can see that the cause is coming because of the perio problem. There is a lateral canal where the bacteria managed to get through it and damage the nerve. So that's the cause of a problem, because the tooth didn't have a decay to begin with. Now, two combined, in that case, you need to focus on both to treat the root canal, and the perio will not heal by itself. You need as well to do periodontal treatment. Those cases, mainly you will find that it has wide pockets around it, and there's even calculus in those pockets. So that indicates that it's a combination of endo problem and a perio problem. Primary perio, that's the easy one, that the tooth is vital. So you just need to do need to do a periodontal treatment to debride the area, and if it's extensive, then extraction. Now, the differential diagnosis between pulpal and periodontal disease. So the etiology, of course, in the pulpal, it's pulp infection. Periodontal, it's a periodontal infection. Generally, we can decide by vitality. In periodontal, the teeth are vital. And as well, we have the pocket. Usually in the pulpal, it's, as I said, it could be a single narrow pocket that's draining around the tooth. And the periodontal, it would be a wide pocket around it. And the treatment for the pulpal is root canal therapy. For the periodontal, it's periodontal treatment. Now for the endo, primary endo, secondary perio, primary perio, secondary endo, it's all we start with endodontic treatment. And then we see what's happened, if it's healed completely for the periodontal. For the combined, you do the first endo, and then you need as well to implement the periodontal treatment For the perio, it just separated. Now, interesting differential diagnosis. So this is how my brain works. Simply, I put differential diagnosis and I start to exclude them. So in the differential diagnosis, when you have a sudden or deep pockets, and you want to know what's this deep pocket, what's happening here? Is it a periodontal abscess? Usually the tooth is vital. Is the primary endodontic lesion, so the tooth is necrotic, and this is very confusing with the vertical root fracture because you are not sure if it's a primary endodontic when the root is root canal treated, or it's a vertical root fracture. So the only way to know for vertical is to send it for CPCT to exclude, to see if it can confirm vertical root fracture. If you cannot see it, it's either surgical or you open the tooth and you hope if it can work, it works. If it's not, then extraction. Cemental tear, it's an interesting differential diagnosis with cemental tear. Part of the cementum is separated from the tooth and that create a big periapical radiolucency, and that mimic the periodontal abscess or the vertical root fracture. However, usually the teeth in the cemental tear could be vital. The treatment for the cemental tear usually is to remove the broken cemental segment. It's periodontally. They need to open a flap and remove that piece and clean it. However, if the tooth, it depends on the situation of the nerve as well. If it's irreversibly damaged or necrotic, you need to do root canal treatment. If it's extensive, then extraction. Developmental grooves usually it happens in the anterior teeth and the lateral incisors from the lingual side. It's a sudden drop. You can see the groove from the cervical margin actually. And usually it happens because the bacteria start growing on that groove and creating an abscess. Usually it's treated by the periodontist because it's from the palatal axis, and or it could be extraction if it's extensive. So the obvious case, when you have a vertical root fracture, maybe if you do it a little bit angled X-ray, you can see the separation. The less obvious thing here for the 1-3, there is a radiolucency on the side and a sudden drop. And guess how we can check what's going on? So you can sometimes with a microscope and with a Explorer, if you can just stretch the gum a little bit, and with a staining, you can see the fracture. Sometimes it's not that obvious, like this case, that was it shows that there is a periapical infection on the 4-4, and because of the big post, we suspect there might be a fracture. The CPCT didn't confirm it, so we have to go surgically because it will be very destructive to try to remove the post through that bridge. And once it was opened, it was conclusive that it's a vertical root fracture. So the treatment in this, because it's a single rooted tooth, is extraction. As we said here, we have cemental tear. Usually there is adhesions. The X-ray on the right is not related, but it shows the cemental teeth segment that you can see it there. Now, this is an interesting case, but sadly it ended up extraction because it was very extensive. You can see there is a big piece of cementum that was separated from the tooth, and that created concavity on it. So just something to keep in mind when you look at the X-ray, you need to look into the small details. Now, to compare between vertical root fracture and cemental tear, with a cemental tear, usually it happens in the anterior. With a vertical root fracture, usually it's the molar because it has a heavy occlusion on it, or you put a big post inside the tooth. Mainly the teeth in the cemental tear is vital. Usually with cemental tear, it's occur in males over 60 in upper and lower anterior teeth, single or multiple adjacent teeth. Most of the fracture fragment can be carefully examined in periapical radiograph, perhaps also by CPCT as well. The pockets measurements, usually it's more than 6 millimeters around these teeth. So it might be, you can see the confusion here. It could be a vertical fracture, it could be a periodontal when you see, and the tooth is vital in such a situation. Common location, we said the proximal surfaces around the root apex. For the vertical root fracture, it's mainly buccal and lingual. Now, developmental groove can mimic the endoperio problem as well. Usually, especially if you have the tooth root canal treated and it still has a sudden drop on the lingual aspect. Usually it happens in the lateral, as we said. Groove usually start on the cingulum as the bacteria reach the epithelial attachment and can cause a periodontal pockets all around it. So you can see it here very clearly how it created with the groove that the bacteria can grow there and create the detachment. So something to remember. Vitality of the pulp is a key feature for the diagnosis. So it will help us to diagnose, let's say, for instance, periodontal lesions from endodontic. It will help us to diagnose as well some cases of cemental tear. Features of periodontal pockets: narrow and deep versus conical shape and wider. Narrow and deep, mainly endodontic. It could be vertical root fracture. It could be, as we said, the lingual groove. It could be primary endo lesions or endodontic lesions. However, the wide one, it could be more periodontal. Assessment of the general periodontal health. It's important when you see that in one quad that there is periodontal bone loss, advanced or moderate periodontal bone loss, to have a look at the other sides. Most of the cases when the patient comes for emergency, you only check that side, but keep in mind that the patient might need a periodontal assessment overall. Both clinical and radiographic examination will lead you to the correct diagnosis. We don't diagnose based on the X-ray, not by seeing just the periapical radiolucency on the X-ray. We would decide that it's aquatic. We need to go through all the testing steps. Now we're gonna go through clinical cases. First case, 64-year-old male, referred for tooth number 26, asymptomatic bump on the gum, and he has a gold crown for 40 years now. So with this case, we can see that the testing was done. Palpation on the 2-6 was positive, percussion positive. He has a wide pockets all around the tooth and the 7-2. However, the cold test was positive, and that's what we were talking about. Mobility grade 3 and swelling. So that's more indicative that the nerve is not the problem. It's more periodontal. It's a primary perio here. So what we are dealing with, normal pulp and chronic suppurative marginal periodontitis, primary perio. So the treatment, because it's a grade 3, is extraction. And for the 7, it's normal pulp and normal periapical, but it still has a primary perio problem, so it needs just a periodontal treatment. Case number 2, 53-year-old male referred for tooth number 27. Dull, aching, and throbbing pain start 3 days ago. The bridge is 2 years old. Patient can't tell which tooth hurts. Some cold sensitivity from the lower left side. Patient took Advil 600 milligram 2 hours ago, and when the patient usually take Advil, it might mask the symptoms. So keep that in mind when the test is not conclusive. So that's why it's important as well when you do the medical, you ask the patient if he took any medications, and especially in the day of the consult. So the testing was done, including 25, 27, 36, and 37. It was only percussion positive on the 36, bite positive on the 25, and bite positive on the 36. But the cold testing, it was within normal limit. So that took us nowhere. So it wasn't conclusive and it's confusing from where the pain is coming. Is it the 2.5, 2.7, or 3.6? But mostly it localized between the 2.5 and the 3.6. So in such a cases, when we are not conclusive what's going on, we couldn't reproduce the patient's symptoms, we bring the patients back. We bring them back after 2 weeks or when their symptoms get worse. So 2 weeks later, we tested again. It's more conclusive what's happening with the 3.6. The 3.6 was sensitive on palpation, percussion, cold testing was lingering, and the bite test was positive. So especially if the patient at this time didn't take Advil, so the tests were more conclusive of what's going on here, irreversible pulpitis and symptomatic apical periodontitis. In that case, it can be helpful as well, just to confirm your result when you are confused between two arches, as we said before, that you give selective anesthesia in the lower arch. If the symptoms stop, then it's more conclusive that your diagnosis is correct. So the treatment started, it was partially necrotic upon access, and the root canal was accomplished in one visit. Now, case number 3, 61-year-old male referred for 2.6 and 2.7, root canal on 1.6 was done 20 years ago. Patient noticed a bump on the gum a few months ago, and the root canal was done on the 2.7 3 days ago by the DDS. You notice in this X-ray that there is a deep cavity on the 7, and there was a pump a few months ago, so it's not there anymore. So the dentist believed that it was related to the 2.7 and did the root canal treatment. And here is the root canal treatment done. Guess what? The sinus tract came back 3 days after the treatment, and he was referred to the endodontic office to see what's going on. So usually it's supposed to heal, but it wasn't before the treatment, it came back after the treatment. And we can see from the CPCT that there's a perforation. I'll go back just for the previous one. You can see in this X-ray, the post is not aligned in the canal, and there is a radiolucency. It's not very clear in this X-ray, but there is something going on in the where at the level of the end of the post. And usually that's when we suspect that there is a perforation or a fracture. So sadly, this tooth is for extraction. Although when the sinus tract came back, it can be traced, but in that case, it wasn't traceable. That's why it was sent for CPCT. Case number 4, 45-year-old female referred for tooth number 2.5 and 2.6. Constant dull aching pain to chewing on the left side, the RCT done on 2.5 1 month ago. Pain still hasn't subsided, starting to wake up at night. And the crown on the 2.6 to 7 was done 1 year ago. So the patient did the root canal treatment, still she has the same symptoms, and now it starts waking her up at night. This is more indicative of irreversible pulpitis. So we did the testing. The testing shows that we have the 2.5 and the 2.6 sensitive to percussion. The cold testing was within a normal limit on the 2.6 to 7. The bite testing was sensitive, so it's a tie. We are not sure what's going on. So in such a cases, when you suspect that there is irreversible pulpitis somewhere and the patient is in pain, but you are not sure what's going on, in your mind, you know it may not be the 2.5, it could be the 2.6, maybe the 2.7, but you want more evidence to support your treatment because you're going to do root canal treatment. So sometimes CPCT might help in those cases. How? When we did the CPCT, we can see the widening in the periodontal ligaments, and it's more possibly it shows that it has irreversible pulpitis, which is a good evidence to support opening the tooth. Root canal was done on the tooth, and it was necrotic. There was pulp stones, and it was necrotic Upon access, there was a recurrent decay in such a case. So you see a crown, you suspect maybe a crack, maybe cavity. And that completes the story in this case. Now, case number 5, a 37-year-old male referred for tooth number 14, bite down on chicken bone 1 month ago, and a sharp pain radiate upon the right side. Patient stated that the area was swollen, but it's not as tender or swollen anymore. RCT and the crown done on the 1/4 in 1999. So the reason why this case was deferred, because they still see radiolucency. So in this case, maybe they suspected there might be periapical infection. Maybe there is a fracture because there is a post there. They are not sure what's going on. So there was some bump, but it wasn't traceable at the consult appointment. And the testing wasn't conclusive on the 1/5 if it's called responsive or not. Everything else was within normal limit. Sent for CPCT to confirm if it's a vertical root fracture, the apical lesion deferred related to the 1/4 or 1/5, and it came conclusive that's related to the 1/5. So treatment was done, joined 2 canals at the apex, and you can even see the traces of the sealer through the sinus here. Sinus healed after 1 month. Now, case number 6, this is the last case. So 59-year-old female referred for 4/5/4/6. This is a difficult diagnosing case. It's not as simple as it perceived. So the patient has intermittent dull ache for about 2 weeks that was previously throbbing. The gum area seemed inflamed recently. Sinus tract noticed between the 4/5 and the 4/6. The root canal was done on the 4/6 in 1999. So the testing was done. The tracing for the sinus was inconclusive as well. So the popping showed deep pocket on the distal of the 5, medial of the 6. The cold testing was negative on the 4/5. The bite test was positive on both. So this shows it's more indicative that the 5 is the problem. So we followed that. And we did a CPCT just to confirm what's going on there because of the size of the lesion that we are dealing with. And it shows a radicular cyst between them both. It wasn't still conclusive. So those one of the cases that you still are not sure, but you would try to treat in a systematic way and least invasive. So the obvious is the 4/5 is necrotic and it's turned into percussion. So it needs a treatment. So the treatment is started on that tooth. However, 7 months later, there was no change in the radiolucency size. So you would think, okay, is it a cyst that need to be removed surgically, or is it related to something else? So surgical exposure was done, and we found a vertical root fracture on the mesial of the 6. So this is a tough. You would argue, like, why don't you start the treatment of the 6? Well, it's a big post there, and it was more indicative of a surgery. We don't know. We found you will hit 2 birds with 1 stone. When you open surgically, you can confirm if there's a vertical root fracture or not, which didn't show on the CPCT, and as well, you can preserve the crown. So in that case, root amputation was done, and the tooth was saved. Now, this is the last segment of our lecture. Difficulty assessment. So nobody will tell the dentist which cases they should treat, which cases they shouldn't treat. It's you are your own judge. You will decide what's your limit. You will decide what can you do and what you cannot do. There is a difficulty assessment form that will help you realize the difficulty of the cases, what you need to check, and it's available on the American Endodontic website. Should I refer or not? Such a cases, I think it's worth referring, but it depends on the level of the dentist. This case seems double the difficulty. You have a crown and you have a calcified canal. So digging through the crown, which is not anatomical, and trying to find a canal which totally calcified in such a case will be a very complex case, I believe, for the general dentist, because you need a higher magnification in the microscope to be able to deal with such a case. Also a calcified. This is sadly wasn't caught earlier. The dentist already started the root canal treatment. You can see the extensive of the damage in the tooth structure. Sadly, this tooth found in the stall based on the CPCT that was there. Now, this case was referred to me, and it's a very interesting one. So we received the case for the 4-4, the upper left X-ray. It shows that there's something inside the tooth. So the story behind it, the dentist started the root canal treatment, seems like an innocent premolar. He started the treatment, and after he finished, he noticed that there might be a missed canal. So he tried to retreat it. And it was more difficult for him, so he decided to abort the retreatment and refer it. We send it for CPCT. You can see how the anatomy is complex there. And it's almost like a C-shaped. And it was done in one visit after got the CPCT, and we know how to maneuver inside the tooth. Now, this is a higher level of difficulty because it's bifurcated deep in the apical part of the root. Now, this case as well, we have the 3-5 deep filling, and it was they started actually the treatment, but they couldn't find the canals, so it was referred. Again, we sent for a CPCT, and the CPCT shows a C-shaped with a trifurcation this time. And the root canal was done once again with a higher magnification. I believe, like this case, from the way you look at the 6, it will show you something going on there. Like the roots are not standard, like regular anatomy. Now, dilaceration of the roots as well, like an S-shaped, just waiting for an instrument to be broken there. So you need to be careful when trying to negotiate those canals. Even an endodontist doesn't want to tackle those cases, but this is our job, I guess. Now, this case, as innocent as it shows, the 2-6, patient has symptoms on it. So it needs a trained eye to look in the pulp chamber and to check if there's something doesn't look right, like there's something going on with the pulp chamber there. You take a different angle, you can see the small radiolucency under the pulp chamber space, and you're wondering what's going on there, which is a resorption case. So when I saw that, I just sent the patient for CPCT because I want to know what I'm dealing with before I touch the tooth. And this case was very extensive resorption case. It was a hopeless case. Interesting thing just to mention for resorption cases, it's multifactorial. We don't know what's causing it. It could be trauma, bleach, or braces, or interestingly, cats. So there's a virus transmitted with the herpes virus from the cats. We ask most of our patients, we trying to run a study, Dr. Nawaya is running a study for resorption cases. So we ask each patient that they have resorption if they have cats, and like I guess more than 99% of them they answered yes, they in their lifetime they adopted cats. So it's just an interesting finding. Usually when you find such a resorption, I would recommend that you keep monitoring the patients on the other teeth to try to catch it as early as possible to stop the process. And usually the treatment is root canal treatment. Now, more resorptive cases. So these are different teeth. The treatment was started, but because of the resorption, you don't know whether you should stop. And sadly, one of the cases you end up with extrusion of the endodontic material, which needs surgical cleaning now. Now, this case as well. It's triple the trouble, as they say. It's 7, upper 7, limited mouth opening. It was root canal treatment was done before with a broken instrument in the mediobuccal root and a missed canal. So it's, I think, on the highest scale of difficulty. It was done on 2 stages. First, everything was cleaned, broken instrument. We managed, luckily, to remove it. And when the patient's symptoms subsided a little bit, we finished the treatment with obturation. Well, that's all. Thank you all, and I hope you enjoyed the lecture. And I hope it was informative for you.